we'll get right on with it. The image in the New England Journal concerns a 9-year-old girl with sore throat, pharyngitis. She's febrile, 38.5 degrees centigrade. She has cervical lymphadenopathy. And when we look inside her mouth, she's got these papular lesions on her soft palate. And if we look at them very carefully, they seem to have pale centers. And in American parlance, these are called doughnut lesions. We're offered a differential diagnosis of 5 items. All of these items can produce pharyngitis, that is to say, sore throat. Since the patient is 9 years old, I hope that we can eliminate Neisseria gonorrhea. And she's actually a little young to show up with Epstein-Barr virus. Measles would cause lesions inside the mouth. They're usually on the buccal mucous membranes, and they're called Koplik spots, and these are not Koplik spots. So we're left with adenovirus and group A streptococcus, and these doughnut lesions are typical, not pathognomonic, but typical for group A streptococcus. Here's another example. This individual also has sore throat, pharyngitis. We don't see a lot of purulent material here, but we see these rather peculiar papular lesions on the soft palate and on the tonsils. And these are called doughnut lesions, so that's the most likely diagnosis. Now, the first topic in the New England Journal concerns bag and mask ventilation. And these instruments are certainly an advance. And with them, we can actually ventilate patients if they cooperate or if they're unconscious quite well. An oropharyngeal airway is also helpful. And these have been a great advance in patient care, particularly in critically ill patients. And the question in this study is, should bag and mask ventilation be conducted when patients are intubated in intensive care units? Now, inside intensive care units, the intensivists are not as expert at intubating patients as anesthesiologists. I feel fairly strongly that the best doctors, the most experienced persons, should conduct the intubation. That's not always possible. So the question is, can we avoid hypoxemia if the patients are treated with high flow oxygen and bag and mask ventilation for several minutes while they're being induced, receiving sedatives and perhaps muscle relaxants before the intubation is conducted? Now, intensivists are somewhat reluctant to do this because rumor has it that the chances for aspiration are increased by this bag and mask ventilation. So a randomized controlled study was done in intensive care units in the United States, and patients were randomized to intubation as soon as possible or bag and mask ventilation prior to intubation with fairly high flow oxygen. So the primary outcome was the lowest oxygen saturation observed during the interval between induction and 2 minutes after tracheal intubation. So if we look at how this was done in detail, we can consider that structured education is necessary. Positive end expiratory pressure is provided by bag and mask ventilation. We'd like to see at least 10 breaths at an oxygen flow of 15 liters per minute, proper position, tight seal, ventilating the patient, etc. These obviously have to be conducted. So if we look at the result, if we look at some of the characteristics of these patients shown here, I was primarily interested in the median time for induction to laryngoscopy, which is obviously a little longer in the bag and mask ventilation compared to no bag and mask ventilation. And the median time to laryngoscopy and etc. And by looking at this little figure here, we can see that the oxygen saturation is a little higher in the bag and mask ventilated patients than in the non-bag and mask ventilated patients, as we would expect. What we can also see is the lowest oxygen saturation, which seems more favorable in the bag and mask ventilated patients compared to no such ventilated intubated patients. Now, I'm not quite sure what happened to this person who has an oxygen saturation here of about 25%, which I can hardly believe. Certainly an outlier, but it's peculiar. Now, the degree of hypoxemia was indeed lower in the bag and mask ventilated patients than in the patients that did not receive this treatment. And if we look at this forest plot here, body mass index, neuromuscular blockade, laryngoscopy, the indications, FiO2 levels, etc. On the whole, it looks like the bag and mask ventilation patients do a little better than the patients that don't receive this treatment. And if we look at outcomes, actually, they're not greatly different. But the median decrease in oxygen saturation is a little better in the bag and mask ventilated patients compared to the other patients. Now, this is not a survival study, and other endpoints, too few patients to look at other endpoints, but the safety endpoint in terms of aspiration during this treatment did not seem to be increased. And the results seem to indicate that for every 9 critically ill patients undergoing tracheal intubation, bag and mask ventilation prevents 1 episode of severe hypoxemia. So there's editorial comment, and the editors observe that it doesn't do any harm. The risk of aspiration pneumonia did not seem to be increased. So perhaps, since the practice is not harmful, perhaps it provides some benefit because of less hypoxemic events in these patients that have to go endotracheal intubation. The next topic in the New England Journal is carcinoma of the ovary, which is treated when diagnosed, and oftentimes not diagnosed early, treated operatively. And the standard operation is removal of ovary and fallopian tubes, and a hysterectomy is performed, and a fairly extensive lymph node dissection is performed in these patients. Now, the question in this study is this lymphadenectomy really indicated in patients with ovarian carcinoma? So in this study, over 650 women with ovarian cancer were randomized to the standard operation with or without lymphadenectomy. Now, because the lymphadenectomy is so extensive, you might imagine that it's also involved with certain complications such as bleeding, increased infection, increased length of operative time, etc. So the endpoint was survival, and secondary endpoints were complications. So if we look at these patients, they're fairly well distributed according to this randomization, and various other clinical features are reasonably distributed in these 2 groups. And what we see here is that in terms of overall survival or progression-free survival, there's no difference in the patients that were treated with lymphadenectomy compared to the patients that had no lymphadenectomy. And since avoiding this additional operative procedure, we might imagine that quality of life and complications are less in the group that did not undergo lymphadenectomy. And that indeed was the case. Operative time was substantially less. Blood loss was also less, requiring post-operative admission to intensive care units was substantially reduced, the necessity for repeat laparotomy because of bowel leakage or fistula events was also reduced in the group that did not undergo lymphadenectomy. So it might be that patients with ovarian cancer who have a difficult road ahead of them anyway would do better if they don't undergo lymphadenectomy, since it seems to accrue no advantage and is certainly involved with multiple complications. The next topic in the New England Journal was hair loss in Africans. This condition, and I show several examples here, is called central centrifugal cicatricial alopecia. And it's also associated with African grooming practices, making these little pigtails and things like that, that also places stress on the hair follicles, etc. And also the use of hot petrolatum and other things that are done can also injure the hair follicles. And the earlier thought was, well, this is a mechanical problem related to grooming practices. But since this central centrifugal cicatricial alopecia seems to show a genetic propensity, it's a little more common in women, but it seems to be autosomal dominant, perhaps some genes are responsible. And that was the hypothesis that was tested in this study. So women with this condition were recruited and they underwent genome-wide exome sequencing, and indeed, not in all, but in some, mutations were found, important mutations, stop codons, etc., in a gene called PADI3. What is PADI3? PADI3 encodes for the enzyme peptidyl arginine deaminase type 3, and this protein was mutated in women that showed a genetic propensity for the development of this form of alopecia. And modeling the protein suggests that the mutations result in protein misfolding. And we can see here's some small family trees. Here, primarily women. Looks like it could be autosomal dominant, although the family trees are too small to draw any inference here. But the wild type protein differs from the mutated protein because of this amino acid substitution in this case that suggests that the protein is folded differently. Now, only one allele is mutated here, but it seems to be an autosomal dominant disease. So it could be that the folded protein interferes with the function of the normal protein, resulting in this condition. So we look at some cell studies here, comparing mutated proteins to non-mutated proteins, and what we see here is that the subcellular location of the mutated enzyme is not normal in these transfected cells. So there's abnormal intracellular localization of the protein with the formation of aggregates in the cytoplasm. So these are loss of function mutations in these women with this form of alopecia. And since the enzyme mediates determination of hair structure proteins, including the cuticle and the inner root sheath, these findings indicate that this condition is in essence a genetic disease, probably adversely affected by grooming practices in these women. I don't think that there are going to be cures forthcoming, but at least the women that are at risk can be advised accordingly. Now, the next paper in the New England Journal, I had never heard of this, I confess. I'm supposed to know something about twinning, but I'm not aware of this. This condition is called sesquizygosity. Now, you'll recall that there are monozygotic twins. They arrive from one fertilized egg. They share their genomes to 100%. They develop in a single chorion with 2 amnions and 1 placenta. And then there are dizygotic twins, which result from 2 separate oocytes being fertilized by 2 separate spermatozoons, resulting in 2 offspring that share half their genomes in common, They can be of the same sex, but half the time they're of the opposite sex. And then there's sesquizygosity. And this is twinning, where the shared genome lies somewhere between 50 to 100%. And we ask ourselves, how can this possibly be? This is a rare condition. Sesquizygosity probably as such is not so rare, but resulting in term births of two individuals, this is fairly rare. And exactly how this works, I'm not quite certain. But we're going to study this. So here are monochorionic monozygotic twins. They should be of the same sex. There are two amnions, but a single chorion, and they're fed by a single placenta. So during ultrasound examinations, when ultrasonographers see this constellation, this is the earliest sign in pregnancy that we're dealing with monozygotic twin pairs. Now, in this particular example, the ultrasonographer observed that it seemed that the developing infants, one of them seemed to be male and the other one seemed to be female. And this is actually not compatible with monozygotic twinning. So some biopsy material was obtained. And what we see here is that both twins are actually chimeras. And one of them is XX, which is female, and one of them is XY, which is male. But they're basically chimeras. And what we see here is that they share, the maternal part of their genomes are perfectly identical, as we would expect for identical twins. But the paternal parts are different. And what we see here is that there are two different alleles here from the paternal portion of the genome. So in order to explain this, we have to imagine that this oocyte was penetrated by two spermatozoans from the father, resulting in this admixture so that his genome is somehow mixed from two sources compared to the maternal genome, which is only from one source. Now the twins, although there was a male twin and a female twin, they share about 89% of their genome in common and not 100%. So this is how this works. So basically, here's the story. Amniotic fluid from each sac showed that the twins were maternally identical, but chimerically shared 78% of their paternal genomes. But what was done here is total genome sequencing, which is today is fairly trivial. So that's shown in the figure here. These twins were therefore sesquizygotic. And a pairwise SNP analysis was done, which is the fastest way of determining how much of the genome these two twins had in common. So if we look at allele sharing, in terms of maternal alleles, both twins shared the same amount of maternal alleles. But in terms of paternal allele sharing, the twins varied from another, suggesting that two spermatozoans were involved from the father to explain this constellation. Now, this is fairly difficult to understand in terms of how the development can proceed under these circumstances, but what is postulated is that there's a single, the spindles here for further divisions come from the so-called pronuclei. And what's postulated here is that a single pronucleus from the mother and two pronuclei from the father result in this spindle apparatus that's shown in this diagram here. Now, the twins were born prematurely, and they seem to be doing fairly well, but the female twin had some ovarial dysgenesis, which required an operation in her at age 3. So her ovaries, she had gonadal dysgenesis, so that in her prophylactic oophorectomy was performed. She also had some thrombotic processes and lost one limb. But otherwise, the twins seemed to develop normally and show no physical evidence of mosaicism, although by genetic analysis, mosaicism was obviously found. The review in the New England Journal is on intimate partner violence. And very unfortunate topic, but we read about it in the newspapers now every day. And the clue here is how physicians can be made aware of this condition when they have to be suspicious that partner violence is occurring, because the partners, generally women that are subjected to violence, obviously commonly don't like to talk about these sorts of things. So we see some vignettes here. And the first person is a 40-year-old woman who is asthmatic, and her partner cannot accept her illness, and he interferes with her care, won't provide funds for buying medication, various things, and tortures her about her illness. And the vignette draws the physician's attention to how a history can be obtained to show this form of intimate partner violence. And the next case involves a young woman with throat pain. She doesn't have pharyngitis. The doctors don't know exactly what's wrong with her, but additional history discloses that her partner tried to choke her to death and she fainted. That would cause throat pain. Very good. And the next case is a 51-year-old woman with headaches, and eventually she shares the history that her partner is torturing her, not physically but mentally, and won't allow her out of the house to visit her grandchildren, etc. So here strategies are presented, how physicians can recognize this condition and how they can possibly deal with it, and internet sites are also given to help doctors in this regard. So how to improve these health services. So that's the review. Now, the patient of the week in the New England Journal is a 73-year-old woman with known chronic lymphocytic leukemia, and she develops systemic symptoms, fever, and a substantial swelling in her right groin, which we might imagine is probably involving lymph nodes. We find out that she's febrile to a substantial degree. She has a white cell count of 19,000, and we learn that in her past history, she has had herpes simplex type 1 infections, for which she receives a cyclovir as needed, and she's also had an episode of herpes zoster. So she has some previous history of infectious complications. Now, in order to correct this case, we have to have some knowledge of what the course of chronic lymphocytic leukemia is. And chronic lymphocytic leukemia can develop into straightforward B-cell lymphomas, and that's called a Richter's transformation. And actually, that was my favorite diagnosis. So what's done here is imaging, and we see with the PET-CT intense uptake in the inguinal area. That's this big node here, and maybe this would be worth biopsying. So that was done, and a core biopsy shows these dense monomorphic infiltrates of small mature lymphocytes consistent with chronic lymphocytic leukemia, and flow cytometry revealed monoclonal B cells, and they have an immunophenotype that's also characteristic of chronic lymphocytic leukemia. So with this huge lymph node, I thought this is probably a Richter's transformation. And so the differential diagnosis here is discussed, and the discussant actually also favors a Richter's transformation, and these are generally then large cell B-cell lymphomas, but also the patterns of Hodgkin's lymphoma can also be observed. And there are various mutations in various genes that could be involved here, and those are also discussed. But also is the possibility of a second cancer that might be responsible for this, or other reasons to have lymphadenopathy, including infections of various sorts. So what was surprising here, then eventually this lymph node is excised, and this lymph node is infected with herpes simplex type 1 virus, which we knew that she had from the history. And I really wasn't aware that herpes simplex type 1, usually where you think of blisters and this sort of thing, can cause this form of lymphadenopathy. But this is a case of isolated lymphadenitis related to herpes simplex type 1 virus in a patient with underlying chronic lymphocytic leukemia. Another patient in the New England Journal. This poor woman had a malignant melanoma in her left great toe. And for that reason, she undergoes PET CTs at periodic intervals. And what's seen here is she seems to have 2 large metastatic lesions in her heart, although she's asymptomatic. And biopsies were performed, and that revealed melanoma metastatic to cardiac muscle. And the melanoma markers, including SOX10, were positive, and the patient was treated with pembrolizumab, and there was some resolution of these lesions, and 15 months later, she's still doing pretty well. The next topic, we now move to the Lancet. We've already discussed GLP-1 agonists, glucagon-like peptide 1 agonists, which seem to be wonderful drugs. They increase insulin release, decrease glucagon release. They make the liver better so that fatty infiltration is lessened. They seem to increase sodium excretion. They're good for endothelial function, and it's even rumored that they improve myocardial contractility. But maybe most importantly, they get the patients to eat less food. Now, these seem very appropriate and successful drugs for the treatment of type 2 diabetes, including hard cardiac endpoints, including myocardial infarction and large vessel disease. Then on the other hand, we're also familiar with SGLT2 inhibitors that impair sodium reabsorption in the proximal tubule in patients with diabetes so that they pee out their excess glucose. And we know that these drugs are also associated with improvements in hard endpoints, in that small vessel disease, progression of renal disease seems to be ameliorated. Plasma glucose is less, the patients lose weight, their blood pressure is better, their uric acid levels go down, and their hyperfiltration is ameliorated. Why don't we give these 2 drugs together? I think that would be a great idea. So we now inspect a study in which that was done. Now, this is not a hard endpoint study, although I'm sure these will be forthcoming. The primary outcome in this study was how much better is HbA1c and how much weight do the people lose. So these patients are all receiving SGLT2 inhibitors, and they're randomized to on top GLP-1 inhibitor given by a subcutaneous injection once a week or placebo. And if we look here, semaglutide was injected here, and men and women are both involved in various ethnic groups and have pretty severe diabetes with the SGLT2 inhibitor. They still have an HbA1c of 8, and their fasting glucose levels are still elevated. And but the randomization was successful so that these variables are pretty well distributed between these 2 groups: diabetic neuropathy, diabetic nephropathy. These patients are pretty sick. And I think this is remarkable. So in the placebo group, the patients didn't lose any more. Their hemoglobin A1Cs stayed at about 8. But in the group that got the glucagon-like peptide 1 agonist, their hemoglobin A1Cs at 30 weeks dropped to 6.6. That's pretty much normal. And the number of patients achieving goal was almost 80% in this treated group compared to placebo. Fasting glucose levels fell from 9 to less than 7. That's pretty good. And patients achieving composite endpoint were 70% in the group that got the glucagon-like peptide agonist. And if we look at this, these variables expressed at the end of 30 weeks in a different way, we can see that over time these patients even get better than they were, and their blood sugar patterns are substantially better than at the early beginning of this treatment. So that looks fantastic in my view. And body weight, they lost another 5 kilos. And you'll recall that with other treatments that we have for type 2 diabetes, they gain weight. But these patients with the glucagon-like peptide agonist lost another 5 kilos. I think that's fantastic. So I think what's also surprising is their systolic blood pressure was reduced, and that was also statistically significant. So a very salubrious endpoint, and semaglutide leads to some gastrointestinal disturbances, nausea and vomiting, but maybe that's in part why the people eat less and lose weight, so maybe this shouldn't be considered to be a bad side effect. So the implications from this evidence is that I think this will be coming, that in patients with type 2 diabetes, these two compounds will be given together, and we'll be interested in looking at harder endpoints reviewing this strategy. The next topic in Lancet was what do we do with patients that come in with ischemic stroke that we'd like to treat with intravenous thrombolysis if they have a systolic blood pressure that's greater than 185. Guidelines say that patients with a systolic blood pressure greater than 180 should not be treated with intravenous thrombolysis. So what's done in this study is that patients eligible for thrombolysis, if they had a systolic blood pressure greater than 150, they received a blood pressure lowering agent before thrombolysis was performed, in the hope that this would improve their outcomes compared to not bothering to lower their blood pressure. So if we look at the patients that were randomized here, fairly large numbers in both groups, and their clinical profiles and their blood pressures, they're around 165, so they're eligible for thrombolysis anyway. And the question is here, if we lower their blood pressure a little bit, will they even benefit more? And the distribution of the patients is pretty reasonable, and if the rhythm disturbances are equally distributed in diabetes and hypercholesterolemia, and the number of smokers, and they all received imaging, so this all looks pretty good. This blood pressure reduction was clearly statistically significant. It's about between 10 and 6 millimeters systolic blood pressure lowering. I don't know if that's of great clinical relevance, but that was the degree that was achieved. I didn't have access to the appendix for this particular paper, so I don't know exactly what the doctors gave these patients to lower their blood pressures, because that was in the appendix. But it is remarkable that the patients who had their blood pressure lowered had a significant fewer episodes of intracranial hemorrhage. This wasn't very common in the first place, but it was less in the group that had their blood pressure lowered, which I think would probably be important. But unfortunately, their Rankin scores were no different. So the authors could not prove that lowering blood pressure in these patients to that degree improved outcomes. And a forest plot seems to underscore that event, so that basically this is a negative study. And perhaps if their blood pressure were lowered even more, perhaps it would have been helpful. No one knows. Now, the next study involves Ebola virus. And a compound has been developed that's called VRC608. And VRC608 is a monoclonal antibody that addresses a protein that's on the surface capsid of Ebola virus. And this antibody was developed from a patient who had survived Ebola virus, an infection 11 years earlier. So investigators found antibodies that he had made, picked this one because it addressed a surface antigen on Ebola virus, and cooked this antibody, made a monoclonal out of it, and this is a phase 1 study to see if this monoclonal antibody is well tolerated by human beings. So that's what was done here. So healthy adults, 18 to 60, were enrolled in this trial. This is a phase 1 study. Incidentally, VRC608 has been tested in primates and seems to protect these primates from Ebola virus. So this looks pretty good. So there are different doses of Ebola, of this antibody given to these normal subjects, and we find that most of them went to college. I guess that's nice to know. And their body weights are as we would expect for normal subjects. And symptoms, they didn't have any. And the kinetics of the antibody look good. It's dose dependent. And so this is a successful phase 1 study suggesting that this material would be of value in treating patients with Ebola virus. And so we're interested to see whether or not the treatment would be successful. It looks like it might be. The next topic is pregnancy cholestasis. This is a relatively rare complication of pregnancy. It has to be separated from the preeclampsia and HELLP syndrome and other causes of jaundice in pregnant women. If cholestatic jaundice develops in pregnant women, the pregnancies have a poor outcome. So the question is, how can we make the diagnosis here? And it's these women usually develop a lot of pruritus, and this suggests an increase in gallbladder acids. And it's rumored that gallbladder acids are possibly a biomarker to separate pregnancy cholestasis from other reasons of jaundice in pregnant women. So this has been now tested in this huge meta-analysis where every published paper on intrahepatic cholestasis of pregnancy is evaluated by these authors. And if we look at that, the studies look pretty good. Here are the authors listed here in these forest plots. But what we see here is that this condition is associated with stillbirth, spontaneous preterm birth, meconium-stained amniotic fluid, and all sorts of things that we'd rather not have. Now, ROC curves were generated here. This is plotting sensitivity against 1 minus specificity. You'll remember that sensitivity is positive in disease and specificity is negative in health. And a perfect test would be a complete right angle here. And these total bile acids show a pretty good differentiation from liver function tests and other kinds of tests that are done in these patients. So total bile acids indeed are a biomarker for this condition. And that's what this paper is about. Total bile acids also correlate well with poor outcomes of these pregnancies. And so measuring total bile acids, it seems to be the appropriate test for diagnosing this condition. Now, the next paper concerns non-HLA incompatibility between donor and recipient for renal transplants. Now, we're all familiar with renal transplant patients having to be ABO matched, although there are ways around that, and matching them for HLA antigens. And the question is, what else in the genome could be of relevance here? And are we perhaps missing something? So in these transplant patients who had been HLA matched as well as clinically acceptable, genome-wide association was done with SNP markers to look for other possible sites, non-HLA sites, incompatibilities that might be associated with a poorer transplant outcome. And what was also done is on certain candidates, then customized peptide arrays were made to look for antibodies against these epitopes to see if they could possibly be of clinical relevance. And so we look at all the 477 transplant patients and their HLA matching and how they were treated and these various things, and then their SNP matchings, and do the SNPs match or not? And what we see here is that for the more SNPs that were not matched in these groups, the worse their survival probabilities. The people that by random chance that had very good SNP matching did a lot better than the ones that had poor SNP matching. And in terms of these peptides that were generated, mismatches are shown here compared to non-mismatches. So it seemed that antibodies were developed against some of these mismatched sites. And if we identify these sites, perhaps the prognosis of transplant patients could be improved. Now, the reviews in the Lancet are important for nephrologists. One of them is on autosomal dominant polycystic kidney disease and the advances that have been made here in terms of cilia function and how PC1 mutations and PC2 mutations function, and the role of glycosylation or not, protein folding, etc., and how this influences CFTR and possibly action of vasopressin and drug targets. And here is a schema of how to proceed in these patients if there's the suspicion that they might have autosomal dominant polycystic kidney disease, and ultrasound examinations, and who would possibly benefit from a genetic analysis, and if they have PKD1 or PKD2, and how to proceed in these patients, and imaging studies that are done, and possible treatments for this, and other associated genetic findings here, and a number of cysts, and these various things are all discussed in this review. And the importance of imaging we know, and the cyst volume and the growth of these things, and the prognostic indications of imaging, implications of imaging are also given. Then there are treatments that have been tried, mTOR inhibitors. We've reviewed the trials on this, blood pressure controls, angiotensin converting enzyme inhibitors, and then lastly, tolvaptan. Somatostatin analogs are being investigated, etc. But tolvaptan seems to provide some function, and that's under discussion here, and other possible therapeutic avenues are discussed in this review. So the next review is on Ebola virus, which kind of fits in with this monoclonal antibody that we just discussed, and where Ebola virus is most common, and the clinical aspects of this, and how this disease develops, and who's contagious and who's not, and what their symptoms are, and how their immune system, lymph nodes, liver, etc., antigen presenting cells, and whatever have you, how this disease develops, and what the clinical aspects, features here that we can expect. I'm sorry we can't see this very well, but there are a number of therapeutic avenues that are being tried, in addition to the monoclonal antibody that we just discussed. And we've discussed some of these clinical avenues already, but if you're interested in this, you should fish this review out, print it out, and read all of this material. We'll finish with this case report. This is a 58-year-old man who comes in with a pretty aggressive prostatitis, and his PSA is 8, and this prostatitis was biopsied, and it grows a mycobacterium, Mycobacterium abscessus, with which I'm not familiar. And the question is, where did he get this? And it turns out that this patient also had a neuroendocrine tumor, which is being appropriately treated, and he looked in the internet and learned about stem cell therapy. So he went to Mexico from the United States, where there's a host of clinics that have sprung up with illicit putative stem cell therapies. And they inject these patients with some sort of cells, and a whole variety of infections have been spread by these bogus stem cell therapy centers. And that's probably where this patient got this mycobacterium and this episode of prostatitis. Thank you very much. That's it in English. If you're interested in hearing this in German, you can stick around for another 15 minutes and we'll try it in German.
Vielen Dank, Herr Luft.
Bitte, bitte. It could have been worse. That's correct.